this is a dental
I've been trained as an endocrinologist mainly in UK, but I had the privilege of working 6 months in renal unit, that too in transplant unit. I must say that was a nightmare. That was something which was a lot of learning. And I'm thankful to God that I'm not a renal physician, because that was one of the toughest jobs as a physician, where you see potassium of 10 walking in or 8.5 walking in, and then the renal physician should be calm and cool. Where I just worked before that was working in endocrinology, and that was an experience to see. And that really scared me to the kidney disease, because while putting a line in and the complications that they suffer of the diabetes kidney disease, and one of the pioneers of peritoneal dialysis there in cardiac unit, where large number of patients also in peritoneal dialysis. It's been a huge experience, and unfortunately, the way India is moving about that, we have a large number of patients with diabetes and kidney disease, and it's well known to nephrologists and most people who are hearing my lecture that the large number, I would say that our data suggests up to 40 to 50% of patients have diabetes nephropathy. I personally feel that one of the biggest risk factors is the dental treatment. If you don't find the creatinine jumping up by a couple of 1 or 2 points, or EGFR going by 10, 15, ask them, have you got a dental problem? So you will have one only medication universally prescribed called Ketorolac DT or something like that, and you'll have. So one of the risks of diabetes kidney disease on those patients with diabetes, I'm talking about my population patients, is ask them about the dental history, ask them about road traffic accident. Today I met somebody who's been having road traffic accident 10 years ago, a young man of 50 with EGFR of almost 55, because he's been taking painkillers. So it's diabetes, and I personally feel the large number of patients have knifed their kidney with NSAIDs or COX-2 inhibitors, and at a significant percentage definitely have a huge number of proteinuria and goes into nephropathy. As you guys well see that most nephrologists would understand that it's our job to make sure, prevent them reaching to the nephrologist until you start screening them early, treat their hypertension, treat them early. I always say that the endocrinologist job is to not be a glycemic doctors. Our job to make sure we prevent them going to ophthalmologist, prevent them go to nephrologist, prevent them going to a cardiologist. That's our primary job. Glycemic control is more a diabetes educated job. It's very easy job for most experienced endocrinologists. Our focus should be clearly on looking for the screening of diabetes nephropathy. And it is also true that it's from Southeast diabetes mortality, which is around the Newcastle area. Huge mortality goes at every stage of kidney disease. And, as a young physician working in a CKD unit, it was a huge traumatic journey. Every day, one death was so common. And looking at that, that's what the mortality is all about, that mortality with the patients right from the proteinuria stage to end-stage kidney disease is quite significant. And this also graph highlights the relative risk of major complications CKD based upon continuous meta-analysis, either of all-cause mortality or CV mortality. So I tell patients, it's not that just the kidney disease that the patient tends to have directly and indirectly would die, but the cardiovascular mortality is very high. So it's very important to prevent them. The UK PDS teaching have clearly told us that glycemic control can improve the, delay the doubling of the creatinine. So glycemic control, besides so many other things which is important, screening, ACE inhibitors, controlling blood pressure, statins, low salt diet, and important, but glycemic control remains the most important aspect in patients with diabetes to control it, which has also been replicated in advanced studies, which show that intensive glucose lowering reduces the risk of end-stage renal disease in type 2 diabetes. So quite significant reductions is found in advanced study with a standard versus intensive control, which is also a reflection of STENO2 trial. If you look at the STENO2 trial, which has also shown that if you're being aggressive right from that STENO2 trial or the captopril, hypertension, statins, has shown that it tends to improve the end-stage renal disease. Also, we all know that kidney has got a prime source for metabolizing besides liver for endogenous insulin, which is responsible for clearance. That's why when the kidney starts playing up, the endocrinologists have a tough time handling it, and the variation in the blood sugar tends to be very high, and the kidney is the main organ responsible for it, either exogenous, and when it comes to endogenous insulin, it's also partly the liver. So about 50% of the endogenous insulin is metabolized through the liver. That's what the portal circulation is all about. So We're not going to talk more about it, but when the kidney starts playing up, sometimes there is also liver disease as well. Then you have a tough time handling the diabetes. The other issue has been if you have a very standard NGSP, standard HbA1c, and if HbA1c tends to be overestimated above 7.5, but estimated HbA1c remains the standard of care in controlling, looking for diabetes control. There are studies about glycated albumin measurement, which may not be reliable in patients with the proteinuria and peritoneal dialysis, but that can help. But as far as the standard of care, if it's NGSP certified program, which is the most HbA1c of most bigger lab, they have certified, and it's very important to understand that these are the HbA1c remains the most important test to look for glycemic control. Self-monitoring glucose, older machines, especially with the GDH-PQQ1, now the most machine, Instant Activa, which is international brand, treatment. So it's very important to monitor the diabetes glucose control who have diabetes. Now, this is what the tightrope is about, the tight control. This slide is there from us last 25 years time. So though the topic remains a tightrope, this is what the tightrope is about. Idhar bhi gir jayenge and udhar bhi gir jayenge. This is what it is. So it is pahar and khai ki beech mein you have to control sugars. I'm not saying it should be 90 to 120. This is for standard type 2 diabetes graph. Depends upon your experience, patient's understanding, who's caring, how much he's eating, what is his BMI. Is he a very thin guy of just 40 kilograms? So the blood sugar of 150, 200 is also okay. So there's no right choice. But any patient with diabetes, this is an issue that you face with. You know, most patients with the CKD and stage 3, 4 require much higher level of glucose to be controlled, and it needs to be understand. At the same time, insulin over years have remained the most important agent. Today's topic, because I know there are topics about GLP and SGLT and DPP4 as well. I'm not going to encroach on that, but insulin remains the most important in later parts of the kidney disease, and that's very important. But at the same time, the role of DPP4 inhibitors and other drugs are there, depends upon the CKD. But the most common cause of hypoglycemia in patients with the chronic kidney disease or when early kidney disease is either sulfonylurea or insulin. And lower, you strict the A1C, you bring the A1C target to lower value of 6, the number of cumulative severe hypoglycemia per 1,000 goes to very high. Especially in CKD, the DCCT trials have shown that if you bring A1C to below 7, you would have an hypoglycemia. So altered metabolism of the insulin and renal dysfunctions have been a problem. The renal clearance, the insulin resistance is quite variable. In acute kidney disease, you may not have an insulin resistance, but gradually, when the chronic renal failure set in, the insulin resistance tends to play up. The initial requirement may significantly drop to 50% or more, but later on, the insulin requirement starts going up. There's a lack of hepatic glucose uptake. The dose is variable. There's not much subcutaneous. So what I'm saying, we give insulin subcut, where the insulin injections are given through the fat tissues. As you know, the most renal patients may not have initial fat in their under the skin, so the absorption can go straight to being instead of subcutaneous to intramuscular. So that can have other erratic absorptions, lipohypertrophy. So there are several mechanisms which tends to play and decides that which one to achieve. And most clinicians and nephrologists and physicians should be able to guide that everybody should not be an HbA1c of 6 and 7, because there is at the same time, desire to control glucose. At the same time, it is the risk of hyperglycemia, which we need to balance on the tightrope. That's what the topic is all today about, that what is the best way of treating it. And hyperglycemia frequency increases with the renal impairment going up high, which is well known to all nephrologists. Lower the eGFR, the higher the risk of hyperglycemia. One of the scariest moments as an endocrinologist or physician is handling the renal patients, that too on dialysis with a variable intake, 3 days dialysis, 2 days dialysis. It's a huge task. When the eGFR, large number of patients walks in and they say, look, my insulin requirement has got to drop up, the first thing you start thinking is about, is a kidney disease, the creatinines have doubled up and so on or not. So there are more hypoglycemic even in a chronic kidney disease. And as I say, that insulin tends to, if the rapid acting can remain for longer, sulfonylurea like glimepiride, like amylyl can stay for a system up to 48 hours time. There's a reduced gluconeogenesis, there's impaired counter regulations, there's a malnutrition, the patient's normally aged, the misinterpretation of A1C. There are several factors which tends to play up. And the risk of hypoglycemia, as we discussed, becomes very high in the CKD. Now, insulin use, somehow, which I feel that most patients tend to go on insulin mainly because they don't have choice, because endocrinologist physicians have been pushing them to go on insulin. But ultimately, when the nephrologists tell them, look, now you have to stop all the drugs because they are not safe for your kidneys, they come back to us to go on insulin. And I think we as a physician endocrinologist fail to impress them to go on insulin early, because they say, look, oh, this is the last stage, that what patient talks about. But unfortunately, insulin is not the last stage. Unfortunately, patients accept that insulin is the last stage, and large number of patients definitely are taking insulin as CKD5 because they don't have a choice. But I think if we initiate insulin earlier, I think we'll not be able to reach what the patients call that the CKD last stage. So there are, oral treatments which can be given in diabetes kidney disease. I'm not talking about EGFR below 30 or 45, like glipizide, a shorter acting sulfonylurea. Pioglitazone can be given in early, but mind it can cause edema, and it's a heart failure as well. So you need to be careful about the linagliptin would be talked about, Dr. Malik, I think, in the next half an hour. So there are drugs which can be given, but today's my topic is mainly talk about the role of insulin. That's why I'll skip. And there are, if you look at the top metformin, in our days, even my medical school days were no. But now the metformin, even in a bad kidney disease, is taken to be safe as long as the creatinine is not progressively jumping up. GLP receptor agonists like liraglutide has quite safety data, including dulaglutide has safety data. SGLT would be again spoken in the next 15 minutes time. DPP4 again would be discussed, but these are drugs you need to think about it. Certain DPP4s are quite safe in kidney disease. Sulfonylurea, mind it, whenever you use sulfonylurea, please use very small dose. Whichever you want to use it, including gliclazide, I would avoid the sustained release to start with. You get a comfort with the shorter acting in the morning time rather than night time. And if you're using sulfonylurea like glimepiride, make sure you use 0.5 milligrams, not higher dose, because you can end up with hyperglycemia. Netiglanide compounds are a shorter acting, so-called, they're not sulfonylurea, but shorter acting, behave like a sulfonylurea. Repaglinide like Novonorm can also be used in patients with the kidney disease. But you have to be very careful when the kidney EGFR starts going 30. The general rule of the thumb is no to insulin except DPP4 inhibitors. So anti-hyperglycemic therapy, if the EGFR is below 30, we'd advise you the only choice of drugs been not simply linagliptin, but other DPP4, fairly linagliptin being safe, and the basal plus or the basal bolus or a mixed insulin regime is the way. Start small, go slow. Once the patients have end up in even proteinuria with the EGFR between 30 and 60, controlling glycemic control overnight is not going to give you good pleasure to patients or to yourself. So the mantra is that whatever insulin you start, you go slow. Now the traditional nephrologists have been quite against long-acting insulin, but I think practice has changed. I used to have a huge discussion about not using long-acting insulin. Believe me or not, I am very comfortable with the 4 units of a long-acting insulin rather than the 4 units of rapid insulin. To go slow, steady, get your comfort level. There's no right dose to start, but most insulin would patients best to have a gold standard therapy, which is basal bolus insulin, and start with a small dose, no specific dose, but there are dose criteria, but A1C criteria of 7.5 to 8.5 at the CKD stage 3 and 4. But at earlier stage, you can have a much tighter control to 6.5. But at CKD 3 and 4, you should have a little above target rather than trying to achieve it. Now, there are different insulin that you can use it. This is a very simple graph which tells you about that rapid acting insulin, the top column, which can be given. Now there are ultra rapid acting, that fast insulin has come up, which you can give immediately after the meals. These insulin, the advantage is that you have to take immediately it can be taken before the meals, because the patients have erratic pattern. They go to dialysis, they have half the day at the hospital 3 days a week. Some patients may have poor intake because of chronic kidney disease itself. So it's very important to use rapid acting, modern rapid acting insulin. Nothing against the regular insulin. If you're comfortable, but they have to take in 20-30 minutes before the meal, and that timing could be a problem. NPH insulin, yes, as good as glargine or detamere or deglutec, but you have to use a small amount of it. The golden rule is 50% of long-acting insulin and 50% into 3 divided by rapid-acting insulin. But don't get scared of using a basal insulin. Believe me not, because if you don't bring the baseline down, you'll have difficulty in playing with the rapid-acting insulin. I've seen that some people are not very comfortable using long-acting insulin. You can withdraw or cut down the rapid-acting insulin, start with the basal insulin. It will increase the confidence, especially if you find your fasting level above 200. Trying to match and give more rapids, trying to squeeze down to the morning blood sugars will not work. Go with the basal insulin, which are very comfortable, and starting basal insulin at a different dose. And the starting alcohol is the total body weight for a 70 kilograms. Could be just 10 to 14 units of glargine or deglutec or any other insulin, NPH insulin that you're comfortable with. And most sulfonylurea and should be discontinued. Do not use sulfonylurea with insulin. I would strongly encourage that. I'm not a big fan of combining sulfonylurea with that too with the basal bolus insulin. If you are, then basal plus sulfonylurea could be the best combination. The DP4 takes the edge off. That's advantage. DP4 mainly in chronic disease have set in, the insulin resistance have set in because of this chronic renal disease. DP4 is not that a powerful agent, but starting insulin calculate the total body weight as follows: 0.2 to 0.3 unit per kg body weight, which comes to around 14 units of glargine insulin equivalent with a GFR of less than 30. So that's what it is. And you can use the either Tresiba, Levemir, or NPH insulin with it. The basal insulin, which is the favorite slide of most endocrinologists and physicians, this is what the graph shows. That's what the normal physiological action is, that the basal insulin acts for 2 to 4 hours. It gives you the flexibility to inject and decrease and increase the dose. Either use a short-acting or a rapid-acting insulin. So the Joint British Diabetes Association says that glycemic controls to improve the quality of life.
Please hurry.
Okay, so just finish it off in, I think 6 or 5 at first time. So longer. So the insulin analog end-stage renal disease, the benefit outweighs the risk, and the best thing is to give you insulin as much as possible. The basal insulin, any basal insulin that you are comfortable with, started, and most studies have proven they are good in all CKD in all stages of the therapy. And you use the basal insulin at a different, and you'll find that basal insulin tends to go down with an EGFR going up. The insulin requirement, the green one with EGFR of 90, and the red one with EGFR less than 30, the insulin requirement tends to be up and down. So any of the lispro, glargine, aspartate can be used in a patient with a renal disease. So coming back to just one thing, hemodialysis patients, be careful. They're the patients sometimes go into hypo during the dialysis time. Most people would avoid the rapid-acting insulin at that time. You can use DP4, repaglinide as well, but the insulin requirement tends to go down, variable between hemodialysis days and a non-hemodialysis days. Comes to peritoneal dialysis, that's another challenge. Avoid injecting into the bag. Give a subcutaneous insulin because there is a risk of bacterial and contaminations. Insulin being absorbed into the polymer complex, that's called a variable absorption, variable degree of blood sugar increase. So avoid intraperitoneal. Some of the peritoneal experts are very fan of it. I'm not saying don't use it. You need to have experience of using it. But most people, please go on subcut insulin. That's a better way of injecting, even in patients with a peritoneal dialysis. And there are studies, small studies, which have shown that it can also create a fatty liver. Once you go into the peritoneal dialysis, it's better to go for subcut insulin in most patients. Know that. Another problem, new onset or post-transplant diabetes mellitus because of the drugs, tacrolimus, cyclosporin, steroids can use new onset diabetes, which you need to be careful on. But in summary, in renal disease, the insulin is the most safest gold standard therapy. I'm not saying early kidney disease, the role of SGLT inhibitors have come in the last couple of years' time. That's an early proteinuria preventing kidney disease, but insulin is a gold standard treatment, that too in a late stage of CKD. Basal therapy, basal bolus therapy, mixed therapy. I prefer basal bolus therapy in most patients. If the insulin requirement is less than 10 units, then you can go with a 1 DPP4 and 1 basal insulin. So that's what it's all about. Using insulin, be cautious, be careful of glycemia, start slow, up titrate slow. Very high risk patients in CKD stage 3 and 4 are the highest risk of patient hyperglycemia. So go slow, steady, and up titrate. Back to the organizers and back to Dr. Jitendra Kumar and Dr. Saket.